So moving from non-squamous to squamous, we've had 2 trials come out in the last 6 months. Keynote-407, which looked at carboplatin, nab-paclitaxel with or without pembrolizumab. And then we had the Empower 131 data that looked at carboplatin with a taxane, paclitaxel or nab-paclitaxel with or without atezolizumab. So 2 studies, very similar patient populations. How have those trials affected how you're treating your patients with squamous cell lung cancer first line?
So I think this is another situation where we're waiting for sort of regulatory approval. That being said, there is a difference in this study, and as hesitant as I have been to look at cross-trial comparisons and in other study settings, here we have data from the Keynote-407 study that shows a progression-free survival and an overall survival benefit. From the Empower 131 study, there was a strong progression-free survival benefit, but there was not a survival benefit, and not even particularly a strong signal that in favor of survival. How that happens is a little unclear to me. I don't entirely understand why you should have such an impressive progression-free survival benefit without overall survival benefit. For me, it doesn't, sort of color much beyond that to me. I would be inclined in this setting with regulatory approval, for instance, of both regimens, still to use the Keynote-407 data, just as Tom said, just as my preferred regimen in the EGFR mutant patients would be the one where there actually is data of a clear benefit. Here, the presence versus absence of a survival benefit between these 2 would lead me to choosing the one that has shown a survival benefit, which is the carboplatin paclitaxel, either a standard paclitaxel or nab-paclitaxel plus pembrolizumab.
And maybe with time we'll get some of that survival data, because it definitely was an immature or interim analysis, so for PFS. So maybe we will see some of that survival data come out with time. Are you doing anything different, Tom?
So I've actually adopted the carbotaxane pembrolizumab. I think some of the insurance companies don't want to pay it, but I think really the squamous patients, it's been so stagnant in our care. And then this is a trial that's been published and peer-reviewed. And I'm hopeful that this will help improve the care for those patients.
And it is an NCCN guidelines, so that does make it a little bit more available to our patients. Now, before this data came out, I was using a lot of platinum gemcitabine in my squamous cell patients. And so sometimes I'm getting calls from the community saying, will you do this? Should I give carbo, gem, and pembro for my patients? So I have said no. I don't know if you've tried that or done anything like that.
My inclination would be say no. I mean, I think you use the combination that showed a benefit, and I think, that might be.
The other thing that I would add is I've found it sort of sobering how poorly we've been able to predict where toxicity would be seen in these combinations. And so there certainly are small studies that we have seen using gemcitabine, but whether there could be a signal in a large study, I'd like to see the large study before I'd be recommending it to people.
Yeah, absolutely. And one of the unique toxicities that I think that we saw with the Keynote 189 was the nephritis. Which my bias is that it's more a pemetrexed phenomenon, not necessarily the platinum agent. So yeah, we definitely have to be careful.